Hi, everyone. I'm Dr. Asha Shahjahan. I'm the GME Director for Health Equity and Health Disparities for Beaumont Health. So I was asked to give you guys a lecture on an introduction to health disparities in vulnerable populations. And I thought to myself, it's going to be a lot more interesting for you to hear about the social determinants of health, where we live, work, play, and pray, from people who are out in practice actually seeing these populations. And I think it also would be great for you to hear about the populations that are in our Beaumont service area. And so you'll get a chance to listen to 3 physicians that are working at Beaumont Health that work with high-risk populations. So I'm going to ask those 3 physicians to join us. And so I'm going to invite my 3 colleagues, Dr. Bobby McClowry, a family physician and residency faculty at Beaumont Grosse Pointe, and then Dr. Laura Ortiz, an emergency room physician from Beaumont Royal Oak, and Dr. Rua El Tarifi, the program director of internal medicine at Beaumont Dearborn. So I will invite all 3 of you to come on. Okay, and so welcome all of you, and thank you all for joining us. So we'll start with Dr. McClowry.
Thank you for having me here, Dr. Shahjahan.
Yeah, Dr. McClowry, it's so great to see you. So you are out at Beaumont Grosse Pointe, and you've been faculty for how long now?
I have been with Beaumont since January of 2018.
Okay, and you're doing amazing work with the LGBTQ population, and we're so lucky to have you as faculty over at Beaumont Grosse Pointe.
Thank you.
So a couple of questions for you. What are some of the disparities that you're seeing in the LGBTQ population?
Sure. I think the first thing to remember with the LGBTQ population is, number one, they do have the same health risks as everyone else. And I think sometimes I always bring that up because sometimes people will focus on the LGBTQ part. However, we do know through multiple studies verified through the CDC as well as large population-based studies, we see increased rates of cigarette smoking, cardiovascular disease, alcohol and substance use, sexually transmitted infections, including HIV, violence, trauma, increased interpersonal violence, and a whole host of mental health issues, including depression, anxiety, body image disorders, as well as a very high risk of suicide.
Yeah, so that kind of brings me to the next question. So it sounds like there's a lot of issues with mental health and that suicide is disproportionately higher in this group than with other vulnerable populations. Can you kind of explain why?
Yeah, the one way I think about it is we live in what a lot of people refer to as a cis heteronormative world. And so that means that our world is focused on cisgender, which means people who identify their gender identity is consistent with what the sex they were assigned at birth was, and heteronormative. So it's expected, for example, that if you are assigned male at birth, you're going to be a man, you're going to be masculine, and you're going to be attracted to women. As a result of that, stigma, violence, and oppression against these populations have been sort of propagated over time. And it wasn't even that long ago that homosexuality, for example, was in the DSM as a diagnosis. It wasn't until 1973 that it was officially removed, and until the late 80s that word actually came out of the DSM completely. And so as a result, there's this chronic stress and pressure on these individuals that persists throughout life. They're sort of unique things that are a part of their experience as being members of the LGBTQ community, such as coming out, partner, and whether it's a legal partnership or marriage, only recently being legal in the United States, as well as being ostracized by members of their family, friends, and faith communities. And so I think all of that together causes this chronic stress model that leads into an increased risk of self-harm and suicide.
Yeah, that's really sad. And I feel like it actually, as physicians, bears a big responsibility on us to really meet patients where they are. What do you think about how can we as physicians, people here that are listening, they're all new residents, just starting their residency and really getting into their training. What is it that we can do as doctors to meet patients where they are?
Sure, and I could not agree with you more, Dr. Shahjahan. So you're starting residency and you're going to hear a lot about evidence-based medicine, or what does the data say? And I'm a big evidence-based medicine person myself. And there's a nonprofit organization called the Trevor Project that is dedicated to mitigating the risks of suicide amongst the LGBTQ plus population. And in 2019, they published a study that I felt was so powerful that in working with LGBTQ plus adolescents, having one affirming adult of their sexual orientation or their gender identity in their life reduces their risk of suicide significantly. 40% of those queried, or 40% less of those queried, were to have had a reported suicide attempt if they had an affirming adult in their life. And in particular, amongst transgender and gender non-binary youth, routine use of the name that they want to be called and routine use of the pronouns that they want to use has been shown further to reduce the risk of suicide. So imagine during your being a doctor on your rotations and being that one affirming adult and really having an impact on a matter that truly is life or death.
Yeah, that is so powerful. And I think we always forget the power that we have as physicians. To really make a difference in people's lives. All of us have gone into medicine saying that we want to make a difference in people's lives. And somehow we go through med school and we start our rotations and we get stressed out and we lose the vision. So thanks for reminding us, Dr. McLaury, to stick with the vision, meet people where they are, and be that change that we want to see in the world. So I'm going to take you off for just a second, and we'll bring you back in a little bit. And I'm going to invite Dr. Laura Ortiz to join us, emergency room physician at Beaumont Royal Oak. Dr. Ortiz, thank you so much for joining us.
Thank you so much for having me here.
Yeah, so you work in a really unique environment. You're an emergency room physician, you work in Royal Oak, it's our biggest hospital in the Beaumont health system. So you see a lot of different types of patients. In terms of vulnerable populations, what's sort of the largest population that you might be seeing or most frequently see?
I think it's hard to say exactly in terms of numbers, but probably the most underserved that we cater to are collection of the homeless, our mental health patients, and then our substance abuse patients. There's kind of a lot of overlap in these three groups. Unfortunately, it's hard to say what came first, but it definitely is a huge number that we see of all these types of patients that come in. And they usually require less medical resources and a lot more social resources, which is kind of what makes it a little bit harder to bridge those gaps.
Exactly. So I think a lot of times we think of ourselves as physicians and we're supposed to take care of the medical problem, whether it is the high blood pressure or the diabetes or whatever the medical problem is. And we often forget that a lot of the social circumstances that you might be talking about, like where you live, like I said before, where you work, where you play, your education status, the zip code you come from, the education that you've had, that plays a bigger role than a lot of our medical conditions in terms of what drives better health outcomes. So what keeps people coming back? Like, I don't want to use this term, but I'm going to use it. We don't like to use the term frequent flyers, but those are people that usually come to the ER over and over again. Why do you think that happens?
I think there are different couple of reasons that they come back. I think one is need and then the lack of social resources. It's hard to know where to go at night when you're homeless, especially if you're newly homeless. The hospital can be like a very easy resource to use. You get a place to lie down. They usually get some food. It's warm, especially in the winter in Michigan's. There are shelters out there, but if you're new or recently homeless, it's hard to know where to go. And then our transportation system isn't set up really well to get patients to the shelters that they may need to go. And another reason that patients come back to the emergency department frequently is insurance and a lack of understanding of what they're supposed to do. So if there aren't adequate discharge instructions, if there's communication issues between what they're supposed to do and their next steps in their health. A lot of times they come back to the emergency department because it's a safety net for them, and they can ask somebody what they need to do. And if they can't see a provider because of insurance issues, the emergency department's a great place to go to get their complaints checked out.
Yeah. So when you're talking about things like you mentioned homelessness, for example, how do we take steps to bridge these gaps? So we know that, if someone doesn't have a place to live, and if they're a diabetic, they don't have a place to store their medication. A lot of times we look at like the hierarchy of life, our basic needs. If our basic needs aren't met, then we're less likely to really do things like diet and exercise and whatever else that we might need to do to keep ourselves healthy. So what are some steps that you do as a provider to sort of bridge the gap with patients that have a lot of social needs?
We set up a couple of programs in the emergency department. Our social workers have resources for the shelters that we can provide patients, along with resources where they're able to check in to rehab for alcohol or drug use problems. We actually recently started a medication assistant treatment program in the emergency department to help with narcotic addiction. So we're able to start Suboxone. We have social workers who can follow up these patients and get them into medication assisted treatment programs. And then we've also kind of paired with the medical students at OUWB to start an outreach clinic at the Hope Shelter in Pontiac, where we provide medical treatment and medications every other week. We also see patients on the streets to try to meet them where they're at. But there's definitely room for improvement. I mean, it doesn't solve, like you said, the need to store insulin. There's such a lack of access in the U.S. healthcare system. And so hopefully we can continue to still address that as time goes on, so we can really serve our patients.
Yeah, so one thing I wanted to bring up also is that we have a tool called the Beaumont Community Resource Network that's powered by Aunt Bertha. And this is an electronic medical record tool that can kind of work as a virtual social worker per se. And so you can actually search a patient's zip code and search for various needs that they may have. And so I encourage you guys, when you are back in your residencies, to ask about the Beaumont Community Resource Network. You can find it online. I can send that resource out to you, but this is a great way to connect patients too, because many of you might be working outside of the emergency room where you may not have a social worker to help connect things. And one of the things that I really wanted to emphasize is a lot of times when we look at social needs, physicians kind of absolve themselves from that responsibility and say, well, that's a social work problem. That's not my problem, or that's not what I'm in charge of. But what I want to remind you is that medicine has changed quite a bit. We are practicing upstream medicine where we meet patients where they are. We're focusing on health equity, which is really trying to help people be the healthiest that they can possibly be. And we know, according to the Robert Wood Johnson Foundation, that about only 20% of what we do clinically makes a change for a patient's health outcomes, whereas closer to 60% of what is their social circumstance contributes to their health outcomes. So we really have to start paying attention to social circumstances and asking the right questions and screening for the social determinants of health to be able to bridge the gap for health disparities. Dr. Ortiz, thank you so much. I'm going to bring you back in a little bit, and I'm going to jump on to our next guest. So I'm going to have Dr. Rua El-Tarifi, who's the Internal Medicine Program Director at Beaumont Dearborn, join us. Dr. El-Tarifi, thank you so much for being with us.
Thank you very much for having me.
So you work in a very unique population in the sense of when you look at all the Beaumonts, we've got 8 hospitals. We all serve sort of different populations, but Beaumont Dearborn tends to have a lot of the immigrant population, maybe even some refugees. Can you talk a little bit about what's unique about the immigrant and refugee populations that you see?
Unique that it has, I think the last calculations, 35 to 40% are Arabs. So I don't know if there's any specific data of how many of those are immigrants and refugees, but I can count a lot of them are those. And I see a lot of them in the clinic. What's unique about these patients, so all immigrants and refugees come from different cultures. What they share in common, they all fled their countries due to war, unstable, conditions and safe living. Most have low educational background. But the most important thing is lack of medical care. Language, of course, is a barrier. But that lack of medical care gets a little tough with, most of them are resistant to medical care too. And that's one of the things that we can talk about later about how we can help them in that regard. But those are the things that are unique about these. populations.
So when you were mentioning that quite a few is from the Arab population, and that has a lot to do with the demographics of the area. But is there a particular illness or something that you see quite often with the Arab population in your patient population?
Yeah, so because of the circumstances they left the country with, so war, unstable conditions, I do see a lot of anxiety and post-traumatic stress disorders in them. The other the thing I see with them a lot is lack of preventive measures. So a lot of them are in their 60s and they never had a mammogram, never had a pap smear, never had a colonoscopy. And it gets tough to convince them because they don't think it's important. They just think, leave it in God's hands. It's not important. Take care of my cough.
So how do you navigate that? Yeah.
Sorry?
I said, how do you navigate that when?
So it's tough in the beginning. I learn my lesson. I never bring it in the first 3 visits. I never talk about preventive measures. I screen, I ask them, when was your last mammogram? When was your last pap? I kind of know to address their concerns. If it's anxiety, if it's their, they want antibiotics. That's the other thing that's common in this population. They love their antibiotics. I think back home, they get it over the shelf, so it's easier for them. They have a flu, they have a cold, so they go out, they go to the pharmacy, give me an antibiotic. So they came with that same mentality here. So the first few visits is gaining trust.
Absolutely.
I don't bring up preventive measures. After the 3rd and 4th and 5th visit, then I start saying, you never had a mammogram. It's easier to know earlier and treat it than to leave it. But at that level, they already we have that trust between us. So then they get to listen.
So it sounds like what you're practicing is establishing rapport, and then also being culturally sensitive, understanding that the way that they may have been interacting with the healthcare system was much different than it is here. And to just assume that right away we want to get to our agenda of us as physicians, what we want to accomplish versus meeting the patients where they are, what they're used to, what they're sensitive to, and establishing that trust, like you said, is so important. So many times we try to do things by the book. Okay, they're here for this. We want to establish this and go on to the next thing. Like you're here for your diabetes. We want to get your A1C. Let's move it forward. But maybe the patient's not ready for that. And I think that's the difference between what I call book medicine and real medicine. Medicine is an art. It's a practice. It's a skill. And you learn it by interacting with people from various backgrounds, and no one patient is the same, right? No one patient.
You're absolutely right. See where they are. You're going to get a sense of where they are. They come in with their own agenda. They want an antibiotic. They have anxiety, especially when they're dealing with anxiety and the post-traumatic. This is not the right time to talk about a pap smear or a mammogram, or you're kind of addressing that. You let them get into a place where they're comfortable now to address what you want for them.
And one last question, how does health literacy play a role in terms of the patient population? And maybe you can even define health literacy for us. If not, I can chime in there. But in terms of how do you speak to a patient, and how does, for example, if you're filling out an after visit summary, which is something all of our patients in the outpatient, and even when on the inpatient, you get a discharge summary, how important is it to understand the health literacy of the patients?
So it's a tough question because, depending on the population, so a lot of these patients are illiterate. Mm-hmm. So it's difficult to get them to understand what you're trying, but you try to break it down. So I speak Arabic, for example. So I get to the after visit part. It's just a separate white paper with a drawing or in Arabic language for them. But it is important for them. They do understand big terms. They do understand, this is not good for you. So it's back to kids and talking to them in their own, depending on their level of education, but bringing it down to a level where they're understanding. And sometimes they don't have to have, I know this is not what we say for all patients, but sometimes they don't have to understand the whole detail of what it is. They have to just understand this is something very important for you. And when you get to that trust, I have patients who tell me, I don't need to understand it. As long as you're telling me to do it, I'll just do it.
Yeah, and I think the interesting thing about that is that many times when we think about health literacy, we think about the fact of, like you mentioned, people who are illiterate. But I also think that many of us are health illiterate. If you think about my father is, he's very well educated, has a master's degree, speaks fluent English. But if you ask him what happened at the doctor's office, what did the doctor say? He's like, something about my blood pressure. I'm not really sure. Like, it's so interesting because how many times do you, like, for example, all of you that are listening to this lecture, you might pick up one or two things, but you may not pick up everything when someone's talking at you, correct? But it's like, that's the same thing in the office. When we're talking at patients or giving them an overwhelming amount of materials of here's to read this and read this and read this, it becomes overwhelming. So I love what you said, Dr. El-Tarifi, is sort of like breaking it down in digestible, understandable pieces for the patient. You may not be able to explain the full picture at one time, but making sure that you're taking steps so that the patient is understanding. And I think teach back is really important in that too, where they can articulate back to you what the plan may be. So these are all just great tools and things of what we're all doing in practice. And so what I'm going to do is bring back Dr. McLowry and Dr. Ortiz and keep Dr. El-Tarifi on with us here. And I just kind of want all of your 2 cents in terms of what are you guys seeing in terms of health literacy? I know we have language lines for translation, but maybe we'll talk to each of you about what do you guys think in terms of talking to populations and helping people understand. And I'll start with Dr. McLowry.
Sure. So I would love to echo exactly what you said, Dr. Shahjahan, which is that teach back method. I have found that to be really enlightening for me in that, when you go through residency, you learn all of the medicine, you think you're really good at explaining things, and you'll explain to a patient, everything that's going on. And I, ask, now, just to make sure I understand, do you mind telling me in your own words, what you think's going on? And it's something completely different. And so I don't think you can overstate how important that is to really truly test the understanding. And like Dr. El-Tarifi was saying earlier, using diagrams or photos and using other tools to get that information across. It's volumes. I think, I forget the statistic, but, something we say in the room, the patient doesn't hear most of it and they don't understand most of it. So having something for them to go home with and digest, on their own time, I think is really key.
You know what's funny? I'm going to share this story really quick, is that I had a patient who was Vietnamese and we had a translator in the room. And I actually had the after visit summary translated. I spent so much extra time going through each step. I wrote it out. I had it in English and Vietnamese. And I was so proud of myself. I was like, oh, I totally did a great job. Patient understands, it's great. And literally like 20 minutes after the patient had left the office, I got a phone call back asking again about the medication. And I was like really frustrated, but then instead of, it's like it's always about, you think that you're not doing a good enough job for a patient to understand. But I think the thing is we have to understand it's a collaborative discussion. And so if the patient has questions, great. I'm there to clarify them, but it just always makes me laugh that I was like, okay, health literacy, I'm going to fill it out. I'm going to do it step by step and really make it digestible. And, it didn't quite work out as I wanted. And that happens in real time. Sometimes you can do everything that you think is correct, or you think you're doing the best that you can, and it still may or may not work. It's about being flexible and being able to change your approach because, like we said, every patient's different. Dr. Ortiz, how about yourself?
I kind of agree with everybody. In terms of teach back. I also think repetition in different ways and then summarizing, giving them the next steps is really helpful. And then just demonstration too. I had a patient who didn't know how to use their inhaler. They said it didn't work because nothing came out. And so we went through, he got his inhaler and he showed me how he was using it. And then he's like, I don't feel anything. And then we looked at how he was pushing the actual medication down, and we figured out that he wasn't pushing it far enough down. And so when I demonstrated that it did actually work, he was so happy. And just that like extra time that you can take with them just to show them, I think is really, really helpful.
Yeah, that's a great point. Always, even showing people like how they take their medicine. So even if it's not an inhaler, so it's like, bring in your pills. Show me what BID means to you, because BID might mean taking it twice as opposed to every 12 hours, right? So I think it's really interesting if you do ask patients to bring in their medication. Show me how you take your medication. Like, tell me how, like, what time of day you do things. I think that is very helpful as well. So that, the teach back demonstration. And then the other thing I just wanted to bring up is making sure that any reading material you give is at the 4th or 5th grade level. A lot of times we have learned all these fancy terms, right? Diabetic ketoacidosis and nephropathy, and we want to use these terms that we spent the last 4 years learning. But what I always say is, you become this doctor, and it's great. I can talk to you, Dr. McClowry, about nephropathy, and I can talk to you, Dr. El-Tarifi, about diabetic ketoacidosis. But when I'm talking to my patient, nephropathy becomes, we've got damage in your kidney, right? You start having to kind of bring your vocabulary down and talk like a regular person. And actually, that's my favorite part of being a doctor, is being able to talk like a regular person and not all the fancy terms. Anywho, we are running short on time. And all of you are so busy, and it was such a challenge just to get you all on here. So I'm so excited that we had a chance to hear from all of you. So I'm just going to ask each of you to just sort of give one last either final thought about the population that you're working with, or maybe a final piece of advice for all of those that are watching, who are embarking on their journey for residency. So I will start. We'll start with Dr. McClowry, and we'll go around.
Sure, great. I think one thing to remember when you are in residency, so residency, I think, is going to be no surprise. It's going to be hard. You're going to be tired. You're going to be exhausted. And it's going to be a really vulnerable state for you at times. And your patients, though, are also in really vulnerable states as well. And I think when, that is something that I've always come back to when I'm walking into a room with a patient, when I'm super tired and getting a call at 3 a.m. to assess someone who's having a spike in their blood pressure overnight, and, collecting myself and recognizing that this person's here, they're ill, and, it's my job to provide the most supportive care that I can. And, I think once I throw statistics out left and right, I promise they're backed by data, but the US Transgender Health Survey from 2015 showed that 33%, or 1 in 3 individuals who identify as transgender or gender non-binary, have had a negative health experience with the US healthcare system. And so they don't come back. And so, making sure that your experiences with your patients are nurturing, positive, and affirming can really go a long way and continue to engage the patient in care.
Wonderful. Thank you so much for being with us, Dr. McClowry. I'm going to hand it over to Dr. Ortiz. Any last words of advice?
I think my biggest piece of advice for residents is to be aware of your bias, both conscious and unconscious. It's going to be really easy to go into a patient encounter differently than, let's say, if you're taking care of an 85-year-old with a hip fracture versus your alcohol withdrawal patient that's in for the 3rd time this month. It's really easy to go into those encounters with very heavy bias. So just be aware of it and see if you can overcome that bias and try to go above and beyond, perhaps, for that patient. A lot of people have probably written that patient off, and if you're the one who can go above and beyond, maybe you can find something that could save their life, or just be the one person who makes a difference so they have a positive outcome with a healthcare visit.
Yeah, I always say nobody wants to be in the hospital. Nobody wants to be sick. Nobody wants to be labeled. Like, no matter how often people come, nobody wants to be there. So putting yourself in that person's shoes, regardless if they've been at the hospital 7 times, 8 times for the same condition, you will, when you flip the script, I say, instead of being the doctor, if you just for a second be that patient, it will totally change your interaction. And the patient will feel it too. So I love that. We need more implicit bias training, which we do have coming soon, from myself and others. So stay tuned for that, and really try to get more implicit bias training. And we offer that here at Beaumont. So you guys are in good hands. So last but not least, Dr. El-Tarifi, any advice that you have?
So I'm going to echo, what you said, Bobby, with residency is tough. You're going to be tired. You're going to be, stressed. But at the same time, I'm going to say it's going to go by so fast. You will you're not going to even remember the 3 years pass so fast. So just enjoy every moment of it. Have fun while you're learning, because when you're having fun, your passion shows, and patients do see that.
Absolutely. Having fun. Actually, I'm sure all of us can say residency was probably one
If you're passionate,
fun times, right? Like so much fun during residency. Like, and you make the best of friends.
that's it.
Wonderful. Well, thank you all for being here and just sort of giving
Have fun by learning from your patients, from your staff, from your nurses, and just show passion when you're seeing your patients, because they will sense it. And these 3 years will go by like, and you're going to come, remember the good things.
Fantastic. Well, thank you guys all for being with us and just giving the residents a really quick glimpse. This was just a really good glimpse about vulnerable populations and the social determinants of health. And so if any of you guys have questions for any of these wonderful faculty members, feel free to find them on email. It's firstname.lastname@beaumont.org. And so thank you all for being with us. I encourage you to reach out to them and get questions answered. They're all spectacular, great teachers, and you guys will learn so much from them. I also wanted to give a special thanks to Christina Crowfoot and Mary Coper for making this broadcast possible. Also, just want to let you guys know, myself and Dr. Gilpin do host a podcast called Beaumont House Call. And we have a lot of episodes on there that are helpful, not only as tools for your patients, but also for yourself for learning. So some that I want to highlight that have to do with social determinants are our zip code episode. We have a racism in medicine episode, implicit bias, and a gender identity episode, and a lot more. So check those out. And I just wanted to say, congratulations to all of you for making it through med school, matching, and being in residency. Welcome to Beaumont. I wish you all the best of luck. And remember, being a doctor, you have the power to make tremendous change in someone's life. And it is quite an honor and a privilege to be in people's lives and being able to make a difference. And I also say this all the time, being a physician doesn't change who you are. It reveals who you are. And so with that, I'm going to let you go. If you have questions, you can email me at asha.shahjahan@beaumont.org. This is Dr. Shahjahan here signing off. Thank you all and best of luck. Bye, everyone.
Bye.